Evening, everyone. I hope you're having a nice, nice Tuesday evening. We are going to talk about a very important topic which affects so many of us, endometriosis. So I think, especially for the Endometriosis Awareness Month, this is very important to raise as much awareness as possible because I think it affects a huge part of population as women, and it's one of the, I think, hardest conditions that, well, it takes very long to diagnose, and I think there is a lot of misconception, misinformation about how it can affect the fertility, our life in general, and the most importantly, what should we do about this, and how can we treat it? How can we help ourselves when we're trying to conceive, and especially navigating during the pregnancy afterwards? That's also very, very important. This webinar happened to be very, very, very popular. So please bear with me. I keep admitting all of the participants. We got absolutely oversubscribed, and that's only just proves that how important it is to discuss this topic, endometriosis, and how many are interested and how many are looking for the answers. So I really hope this will be very, very informative. And I will encourage you, please use the chat, and you can let us know your name, where you're dialing from, and your questions as well. And we will have a Q&A session after the presentation. And let me just see if we can start. I still have to continue meeting everyone, but I think Dr. Sami, if we can share maybe the slide, and we're slowly going to start, and then I will just monitor the screen. So my name is Maria. I am a fertility nurse by the background, and I'm a founder and CEO of Plan Your Baby. We are a fertility and pregnancy telehealth clinic operating in UK, and we are offering all sorts of treatments. And today we are going to talk about endometriosis and fertility. And I have our wonderful doctors tonight joining the presentation and the webinar. Dr. Sami Musawa, he is a medical director at Plan Your Baby, and Dr. Nora as well. She is a fertility specialist, and she recently joined Plan Your Baby. So I'm very excited to have you both tonight. And we are going to have a Q&A session after the presentation. So Dr. Sami, would you like to go to the next screen? Yes. So myself, yes, I'm Maria, and our fantastic doctors joined us tonight with extensive experience. And they both have more than 20 years of experience each, and worked in the busiest hospitals in the country and private clinics as well. So yes, definitely, please type your questions, because I think this is the safe place to ask your questions, and also, most importantly, the experienced doctors will provide you all of the answers. And then we have Vivi, our senior fertility nurse as well, joining us tonight. And we are going to help our doctors to answer your questions during the Q&A session. Dr. Sami, would you like to go to the next slide? Thank you. So perhaps I will maybe just give you a minute each maybe to introduce yourself, and then we can go ahead with the presentation.
Thank you, Maria, for that introduction. So yes, I'm Dr. Samuel Musawa. I'm the medical director and fertility consultant at Plan Your Baby. And yeah, I've been doing fertility for a long, long time. It's something that I really love. Helping people to achieve their dream of having a family or expanding their family is just something so amazing that I feel privileged to be able to be part of that journey for people. And I've worked at different clinics, some of the biggest clinics in London, and it's helped me gain a lot of experience and knowledge, which hopefully we can then pass on to our patients.
Hi, I'm Nora Sally. I'm a specialty doctor in fertility and sexual reproductive health. And I'm very pleased to be here, and I recently joined Plan Your Baby. I've also got good experience in different aspects of fertility and family building. So please feel free to ask us anything anytime.
Thank you so much. Okay, so in terms of the fertility care and how we provide it at Plan Your Baby, I think very proudly I can say that we are the only clinic in UK that operates across the country nationwide. And we do provide all range of treatments starting from diagnostics, consultations, then non-invasive treatment and IVF, egg freezing, and most importantly, pregnancy monitoring. And perhaps many who already been in contact with us, you will know that we do provide the consultation through the video call, and that adds a lot of convenience, so you don't need to travel anywhere. Appointments can be booked absolutely with no waiting time, and then one of our wonderful doctors will make a treatment plan that our team will share with you the same day or the next day. And then all of the investigations and tests can be done at the closest location where you live or where you work. And we have now more than 450 locations across the country, and even in some rural areas like Wales and Exeter and even Scotland. So, and we provide the results with the same day with no delays, especially when it comes to your treatment, because we understand how important it is to receive all of the results on the same day and provide you all of the instructions. And everything can be accessed through the digital infrastructure we have built. We provide medications as a delivery to your doorstep, and all of the ultrasound scans as well can be performed at the comfort of where you live. And now, recently we have introduced mobile phlebotomy. So actually patients benefit from the blood draw at home. We can send the nurse to your home, blood can be taken while you're having a cup of tea, and then our courier collects it within 10 minutes, and the same reporting, same day. And then we, after the treatment plan has been made, and we can then start the process of IVF, if it's IVF, or if it's pregnancy monitoring. So it all starts with no delays. Dr. Sami, would you like to go to the next slide? Yes, and one of the conveniences that we also added, because we understand how important it is to communicate with your nurses and doctors, is the WhatsApp. So you easily can message us at any time, and our clinical team will be with you shortly answering your questions. And especially when it comes that you've missed the injection or you forgot what you need to take, so you always can let us know. And yes, and our team always will be there hand to hand to support you. And here we can see the absolutely massive coverage by Plan Your Baby nationwide. And I think it's one of the most unique approaches that the clinic ever taken in the fertility history in UK. And this is what we are really, really proud, that the mission, what we've had when we started this clinic, to make really fertility care being available everywhere, we are slowly achieving it. Okay, let's go to the next slide.
I'll take over now.
Thank you.
Thank you again for that, Maria. So yes, today's talk is about endometriosis, and firstly, what is endometriosis? That is the question that we always start with. So I think many of you might know this already, but just briefly go over it. It's a condition where the endometrium, which is the tissue very similar to the lining of the womb, starts to grow or develop where it shouldn't. So normally it should just be inside the cavity of the womb, but it may grow on the ovaries, on the surface of the uterus, on the fallopian tubes, on the bowel, even on other abdominal organs. And then this tissue can cause bleeding and cause inflammation and cause scarring, which then has impact. It can cause then pain and painful problems for the patient. It can cause infertility, which we're going to talk about, and it can cause even some unusual symptoms like passing during the menstrual cycle, passing blood in the stool. Some women can get that as well. So it's quite common, actually. We think about 1 in 10 women will have endometriosis. Of course, at varying degrees. The majority of them, thankfully, is not severe, but sometimes some women, I remember I used to be surprised. Sometimes I would do a laparoscopy, a keyhole surgery, to look inside the tummy for something just different, not to do with endometriosis or fertility even. And we'd find quite severe endometriosis. And then I'd ask the patient when she wakes up from the surgery, do you have any pain? Do you have any problems? Your pain appears very painful. And she said, oh, no, nothing at all. And I'm quite surprised because it didn't really match the picture I saw inside. So there are some women who have what we call silent endometriosis as well, where it's not really causing huge problems for them, but they still have it. And because of this, a lot of the time it takes many years before a woman will get her diagnosis, 7 to 10 years, which is a really long time. Average is probably around close to 9 years in the UK. And some of it is because there's a lot of overlap with other symptoms, things like IBS, and some people consider it as it could be considered as normal menstrual pain when it's not, and this can lead to some delay in diagnosis. But the problem that we face is that 30 to 50% of women with endometriosis have fertility problems. They have difficulty in conceiving, and it is the number one cause of pelvic pain, chronic pelvic pain in women. So it's quite a serious thing, but yeah, sometimes it can be silent, sometimes it can cause a lot of issues for the woman who has it. So how does it cause problems with fertility? Well, first of all, I'll start by saying that having endometriosis does not mean that you can't get pregnant. Actually, most women I've seen with endometriosis will have successful pregnancies, and actually many women with endometriosis will get pregnant without needing fertility treatments even. They get pregnant naturally and sometimes even easily. So first of all, that's something important to understand, that endometriosis is not infertility. It doesn't associate with that. But there have been, strong links with endometriosis and reduced fertility or infertility or subfertility. And it could be due to various factors. These are mainly, some of them are, things that we've observed, and some of them are theories. So structural and physical problems, things like the anatomy of the pelvis, because of the scarring that happens due to the inflammation, the chronic inflammation, the tubes can get kinked or blocked. There can be changes in where the ovaries are located. So there can be changes to the anatomy of this woman. And sometimes the endometriosis can form cysts on the ovaries. We call these endometriomas, and they can eat into the healthy ovarian tissue and reduce the egg reserve for that woman, AMH. Not all women with endometriosis have this, but there are some who will. And then we end up with a lower egg reserve compared to what we would expect for her age. Some women would have had surgery because of their pain, etc. They would have go through surgery. They would have had these endometriomas cut away, or the tubes, cut into, and that can disrupt the blood supply to the ovary, and that in itself can cause difficulty with getting pregnant. And then dyspareunia, which means pain during intercourse, is quite a common feature. It's not an essential feature, but it's a common feature. It depends also on where the endometriosis is located, which can vary from woman to woman. But if there's very painful intercourse, then sometimes that puts people off having intercourse, and they don't have intercourse, and that makes it difficult then to get pregnant naturally if they're not having frequent intercourse as they should. Then there are other hormonal and cellular changes. Some of these are they're still theoretical, but definitely there is a chronic inflammation going on in the pelvis. And that can, in some circumstances, activate the immune system in ways which leave the body less favorable for future pregnancy. And that's something which we see more commonly with women who have endometriosis compared to women who don't. There may be also some hormone imbalances. Progesterone receptors, for example, may be disrupted. The lining, the receptivity lining, perhaps, we think might also be affected. And there is some theory that the egg quality may be impaired because with endometriosis, with that chronic inflammation that we mentioned, there is a change in the environment, in the follicular fluid. So that within the ovary, there's a follicle, which is where the ovary will develop the egg, which is going to be released that month. And that fluid can change in nature. There can be cytokines released, which are protein activated in the immune system. It can change various things, which can then perhaps affect the egg quality. But, saying all of that, still, it doesn't mean that a woman who has endometriosis, all her eggs are bad. And we know from experience that there are many times where we've seen women with endometriosis and they get pregnant naturally without any difficulty, or even if they do need IVF, for example, we don't necessarily see big problems from that. So, these are things which are varying in their influence. So, surgery, yeah. So when I was an early stage doctor, when I was training still in gynecology, I was taught that laparoscopy is the gold standard procedure. It's the way that you tell if this person has endometriosis or not. And laparoscopy is a keyhole surgery. It's an invasive procedure where small cuts are made, about 5 millimeters to 10 millimeters, usually 3 at least, in the tummy, going through the umbilicus. A camera is inserted, and then there are 2 other instruments that go into the pelvis to do the surgery. And gas is used then to inflate the abdomen so that you have space to do the operation. And yes, definitely, you can see quite clearly sometimes the endometriosis. You can see patches of it in the peritoneum, which is the lining of the abdomen, of the abdominal cavity. You can see it on the ovaries. Sometimes you see it on other places like bowel, etc. And sometimes it's quite clear that you can see. And also you can take biopsies, which means you can take samples to check if that endometriosis is definitely endometriosis. And that is kind of the most definitive way to diagnose it. But laparoscopy is a surgical procedure. It's something that has risks. It's not easy to go through it. There's some pain involved. There's anesthetic. There's risks to bowel, bladder, blood vessels. It's not something that really you should do unless there's a good reason to do it. And just for the sake of diagnosing endometriosis, we're moving away from that now. So now, definitely, there are other ways that you can have strong suspicion for endometriosis, such as, first of all, taking clinical history, things like symptoms, painful periods, pain during intercourse, cyclical bowel pain or bowel symptoms like bleeding I mentioned. These are all quite suggestive of endometriosis, well, not diagnostic. And what can sometimes be done is that you can give a trial of medication to create like a medical menopause, GnRH agonists. And there are other drugs that can be tried as well to suppress estrogen production. And that suppression of estrogen will not then fuel the endometriosis, and it will settle down. And if your patient gets better after 2 or 3 months of these treatments, then that's also pretty suggestive that there's endometriosis. Ultrasound is very important as well. So you can get lots of suggestion from ultrasound. In fact, ultrasound in the right hands is probably even better than MRI, because you can check mobility of the ovaries. There's things like sliding sign that you can see, mobility of the pouch of Douglas, and if there's any obliteration. You don't get that with MRIs. So if someone is very well trained to do endometriosis scanning, they can actually, again, give a good idea as to whether there's endometriosis or not. And then there is MRI as well. But laparoscopy is still the gold standard, it's the most definitive way, but something that we try and avoid because of the risks. And laparoscopy can be diagnostic laparoscopy. It can be excisional surgery. Excisional surgery means that you would need to see a very specialized surgeon. You shouldn't do this with any surgeon, because they will cut away the endometriosis. When you see endometriosis on laparoscopy, a lot of the time it's the tip of the iceberg. So there's a lot more deep-seated endometriosis, which then can be near vital structures like the ureter, which is the tube that comes from the kidney to the bladder, like the certain blood vessels, like the bowel, of course. And you don't want this to be injured, because then there can be serious complications from that. So the more experienced the surgeon is, the less likely that will be happening, although it can never be completely prevented. So you need someone quite specialized to do this. You shouldn't do it with any gynecologist, unlike a diagnostic laparoscopy, which any gynecologist should be able to do. It comes with a higher cost, as you can see, and higher risk. And especially if you're removing endometriomas, if you're removing cysts from the ovaries, then there can be, like we mentioned earlier, damage to the egg count. The number of eggs will be reduced, the healthy ovarian tissue will reduce. And if the gynecologist is a little bit over enthusiastic in removing the endometriosis and removing these endometriomas, I've seen some cases where egg reserves really plummeted, and the AMH has gone from something really good like 28 to something like 2 just post-surgery, because they did a little bit too much, really more than what's needed. And you can never cure endometriosis, so it shouldn't be the aim. It's not like cancer surgery, you try and remove as much as possible to cure. This isn't going to happen, unfortunately, with endometriosis. As long as that woman is still having her cycles, she's going to unfortunately grow it back again. So it's the idea is to do as little as possible. That's usually best, especially when it comes to fertility purposes. So the only time I would recommend endometriosis usually is not for fertility purposes, but if the woman is having pain, which is affecting her quality of life, then it may be worth considering. Okay, Dr. Nora.
So, thank you. So there's different ways to approach fertility or to think about fertility. There's no right or wrong way. Each person is unique. So when we have a patient with endometriosis, we like to see is there any endometriosis in the ovary? Is it obstructing anything? Can we access the ovaries in IVF or not? So we take into account the whole history of the couple and how long have they been trying. Natural conception and pregnancy is possible. If the tubes are open, many get pregnant by themselves, but sometimes may experience subfertility later on when they want to expand their family. And, We did touch upon the egg quality. So it was found that even at the same age, there might be slightly delay in getting pregnant naturally. So we always ask them, depending on the age, to just be a bit more patient, but we do offer other options as well. When it comes to, again, couples trying for some time, we check them both, sperm, eggs. We can always offer IVF or egg freezing, depending on where the person is in their life and how and when they want to start their family. So egg freezing could be offered before surgery if, especially if they want to undergo radical surgery to excise as much endometriosis as possible because of the pain. Now, and if they're very young and they're not ready to start their family, they can go ahead and freeze their eggs, just like having money in the bank for another time. And once eggs are frozen, they don't age and they don't change and they do stay as they are. If a person is ready to have a family, so they can proceed for IVF, or ICSI, depending on the sperm. And, as long as the ovaries are accessible, we can still do IVF and collect the eggs with a small procedure under sedation. And, she can carry on and get pregnant. We give antibiotics during the procedure just as an extra precaution because we don't want to increase the infection. And during egg collection, we just avoid endometriomas. It may impact the number of eggs we may collect, but we don't puncture endometriomas. So that's one safety key point just to remember. So another point is once we transfer embryos and if there is a positive pregnancy test and, we have sustained level of hormones, that actually helps to switch endometriosis off for a while. So you get a small break from all that pain and stuff, so it doesn't cure it, but it suppresses it for the duration of the pregnancy. Just one other thing to mention is with egg freeze and IVF, once, let's say the hormones, if there's no pregnancy or we finish the egg freeze cycle, sometimes there's a small flare up of symptoms. And because we're aware of that, we know to start painkillers early. So there's nothing to worry about. The flare symptoms are not very common. Lastly, if we can't access ovaries, and it's really important to get that fertility treatment, we may require surgical intervention, but we do not want a lot of excision, just simply draining that endometrioma or cyst without much manipulation, just so that we can access. But we usually can just go around and collect the eggs. Thank you. So next slide, please. Thank you. So just to go over an egg freeze cycle, what it looks like. So generally, once you get your period, we check day 2, we do blood tests just to assess the hormones, AMH at baseline, and to do your scans. Once we have an agreed plan, then we start the stimulation, which are, small injections that we teach you how to take for about 10 to 14 days. And we monitor you during that phase, every few days, a bit of scans and blood tests to see that you're taking the appropriate dose. We don't want to go too high or too low, but we want to, and that's why we need to monitor you in case we need to, alter or tweak the dose so that we have a nice sweet spot of balance there. And once your eggs, the follicles are a good size, and we anticipate a good amount of eggs, and they're ready, we provide a trigger injection here, and then you'll be ready for egg collection. Most of things can be done locally, except at the time of the egg collection, it's done with partner clinics. So, you would come in, just have a small procedure under sedation, and then go home the same day. We will give further instructions just for you to anticipate that you're going to get your period, within the first week. And then we go over how many eggs were retrieved, how many were mature, and how many were frozen. And depending on each person, there's no right or wrong. You can have more than one egg freeze cycle if you like, to bank more eggs. Okay. Next slide, please. So the other treatment, just to take another idea, again, it's the IVF treatment. So as my colleagues just mentioned, that everything is done locally. You can even have your bloods done at home at the comfort. and get the results very quickly. So again, it starts where we have baseline bloods. We check your hormones, check the scans, and if we're ready to go, then you would have the stimulation cycle similar to the egg freeze for 10 to 14 days. There will be monitoring every few days with scan and bloods, again, just so that we have that sweet spot. Not too much, not too little, because we really want to get a good number of eggs. And once we're ready, you take a sugar injection, and then you will have to come in to the partner clinics in London and have the egg collection done again under sedation. The only difference here is after the egg collection, you'll be starting, special hormones to thicken the womb lining, and then you will come in for an embryo transfer once embryos are ready. If we have a positive pregnancy test, then we can do monitoring for that, especially in early pregnancy. We want to give that reassurance that things are going the right way. So every few days, we might do some blood tests to monitor progesterone levels and top up as needed. And then at a certain point, we'll do a viability scan as well to check the baby. So I've covered that in the previous slide, but I just want to emphasize that we do like to take care and monitor even after the embryo transfer journey. Okay, we even are happy to follow patients with a positive pregnancy test, even if they didn't have the IVF with Plan Your Baby. We can also provide support throughout your pregnancy journey as well. And every 2 to 3 days, we monitor and adjust and top up progesterone levels as needed. Next slide. Sorry if there's a bit of a delay. Okay, so endometriosis in pregnancy, we mentioned that endometriosis can, shut down in pregnancy, and it's the same pregnancy monitoring that is done, bloods and scans early on. We can follow until 12 weeks, and then you can monitor. Once we're happy that there's a baby's heartbeat, we will follow up every week with bloods and scan. And then once we reach that 10 to 12 weeks, then we would advise that we have early screening, which is the national screening that's done, or an IPT, okay? Then you would have your regular obstetric care in the second and third trimester. There are some complications that can arise. It could be attributed to the IVF or endometriosis, such as miscarriages and preterm births. But again, because you're being monitored, we are, to be honest, most women are having normal babies and everything, and they're very healthy. And endometriosis does not increase birth defects. So I just have a case here to share. So we have a 36-year-old lady who had no previous pregnancies. She was on the contraceptive pills for quite a long time and then decided to try for a pregnancy. So we stopped the pills for 4 years. Okay, she had regular periods, no pain, nothing, and they weren't heavy. But suddenly, 2 years before she came to seek IVF, she had sudden acute tummy pain that they had to take her urgently for surgery. And at that point, they discovered she had severe endometriosis. So it was silent all her life, as we were just mentioning. So she required to have 2 keyhole surgeries to drain big 8-centimeter endometriomas that were causing severe pain. And furthermore, she had 1 robotic surgery to resect things. They checked her tubes were open, but she was still not getting pregnant. So when we looked as well, we had a retroverted uterus. It means the uterus is looking the other side. And, it's a very common thing. 20% to 30% of women have it, and they get pregnant naturally. Her cavity was normal, slightly adenomyosis, which is slight thickening. And she had a tiny endometrioma there, but she had a wonderful egg reserve. Her AMH was 38.3. So, at this point, there's no explanation why she couldn't get pregnant naturally. Her male partner also did the sperm test twice. There was only some slight changes in the sperm forms, but generally, things were looking good. So we started the IVF cycle, and we did a freeze-all ICSI cycle. And the egg collection was done under antibiotic coverage, and we had 8 blastocysts. So the patient had 2 embryo transfers, but wasn't pregnant. And then we repeated a third one. We just added extra support with Lubion, which is injectable progesterone. And she has a baby that is completely healthy. One other case, just to show you how endometriosis is, again, an enigma. It's a very big mimicker. We have a 35-year-old lady. She had 2 pregnancies, but unfortunately, one was a miscarriage and a termination. And I'll come to more details in a second. But this couple was trying for 7 years, and she had bilateral endometriomas. But you see here, she's already known to have deep endometriosis. MRI was very clear in that. And she had severe menstrual pain, chronic pelvic pain. She did tube tests. It was patent. She had 3 IVF cycles, different types, short, long, didn't make a difference, but we got 6 embryos, double embryo transfers each time, but not pregnant. The embryos didn't develop as such, and that could be because of biology. Then after those IVF, she got pregnant twice, naturally. So she had a miscarriage and then unfortunately had to terminate because of a birth defect, which has nothing to do with endometriosis. It was just by chance, but it was a very traumatic experience. So when we saw her, she was seeking more IVF, but when we saw her baseline hormones, the FSH, which is an important hormone called follicle stimulating hormone, was a bit too high. And when it's really high at this range, there is a high chance that the patient might not respond to the cycle. And if we look at her AMH, it was 2.3, indicating it's a very low egg reserve. So AMH with natural pregnancy, it doesn't affect it. As you see, she got pregnant naturally. But for IVF, it tells us how confident we are that we're going to get eggs when we stimulate the ovaries. She's tried a lot of things like diet modification, gluten-free diet. She's tried a lot of things to try to improve her symptoms, but we don't have any strong evidence for that. Again, the sperm test was there and it wasn't, bad either. And now they're ready to, undergo. And her main question was, well, I still have pain. Can I carry on with my fertility, or do I just do surgery for endometriosis? And with a very low egg reserve, at that point, it may not make much of a difference. So maybe to manage her symptoms was rational because she was suffering. But we gave her the information, and she decided later to have surgery and underwent 2 laparoscopic. One was a robotic surgery and, removed both of her tubes and the endometriomas because the tubes at that point were swollen. So the tube test she had done was more than 7 years ago at that point. And she had so much pain, and they removed the tubes. And then after that, she had, one IVF cycle with donor eggs. The first transfer was a miscarriage. Second transfer, she had a live birth. The one thing I wanted to stress is the mental health. So please, there are counselors and psychologists with our service and with any other service. If you need them, just reach out. I know we try to cope, but you see, this second patient, postpartum, sometimes used to have night terrors, waking up that, something has happened to the baby, or, the baby's being harmed or not breathing. So this journey was very stressful for her. So please just take care of yourselves as well.
Thank you so much, Dr. Nora and Dr. Sami, for such insightful slides and information. What I will do from my side, I will go through some important topic, costs, but I will not spend too much time because I can see we have more than 100 questions, doctors. So honestly, and I kept reading them, and I really would love to answer as many as possible. So Plan Your Baby has multiple packages for egg freezing, and one package starts from 5,500 plus fee for medications, which always will vary based on your medical history and your personalized protocol, and that would be around 1,000 to 2,000 pounds for medications. And we do take care of the full services. We arrange all of the blood scans during the treatment for you, and it's very, very personalized treatment. You will have your bloods and scans done during the stimulation every other day, and sometimes every single day, just to provide the treatment with the precision. Dr. Sami, could we go to the next slide, please? So IVF treatment is more expensive because it requires the fertilization of the eggs and sometimes even freezing the embryos. So the fees per cycle varies between 8,500 to 10,000 pounds, and that would include your medications, all of the blood tests, ultrasound scans during the treatment, and then the egg collection, fertilization, and if it's a fresh embryo transfer, would then proceed with a fresh embryo transfer. And the treatment, yes, it can be done as the embryo freezing if the surgery for endometriosis is required afterwards. Dr. Sami, next slide. So in terms of the management and what we are trying to do for our patients during this journey, it's the nutrition. So we do support our patients with the consultation with one of our wonderful nutritionists, and we do try to provide it as soon as possible so you can have more time to prepare your body for the potential treatment. And also we do provide consultations with the psychologist during the treatment, because as Dr. Nora said, the most important is to look after yourself, the mental health, and this journey is absolutely far, far, far away from being perfect and ideal. And I'm sure no one wish and wake up with the idea, why don't I have IVF tomorrow? So, yes, it can be heartbreaking, but it's important to look after ourselves. And then, yes, we also would support the community to join the Endometriosis UK, and you can speak to, other ladies who have suffered from the similar situation or symptoms. And I'm sure, by surrounding yourself with people who can support you is very, very important during this journey. Dr. Sami, can we go to the next slide, please? Yes, so one of the differentiators how Plan Your Baby works is, number one, we are working 7 days a week. If we have to perform your blood test and scan on Sunday, believe me, you will have it done. And we work extended hours from very, very early in the morning until very, very late at night, 7 days a week. So you always can get hold of us and speak to our members of staff. And in terms of your treatment, we are really focused on the personalized treatment. And we truly believe that this is what exactly maximizes the chance for success, because every single body is very different and absolutely can't be treated by the standard protocols and assuming that everyone, has the same hormones, same diagnosis. So we always personalize the treatment according to your situation. And we were very proud to receive multiple awards last year, and 2026 is going to be even more exciting for us. Can we go to the next slide, please, Dr. Sami? Yes, so I will perhaps not stay on this slide too long, but we have a QR code to book a free consultation with Dr. Nora. But don't you worry, we're going to share this link in the chat. So please monitor the chat, and you can book it just by clicking the link. And we are going to start the Q&A session. And I know that we have a lot of questions, and we will try to answer them all. But also, if we not gonna have time, don't feel upset. Please just email to us, and my colleagues will provide the email address in the chat, and you can email us your questions or book a free call with Dr. Nora. Okay, Dr. Sami, Dr. Nora, I will ask the first question, and let's try to help as many as we can. So, hi, I'm Raina from UK. I have had tubes tied and have endometriosis on my ovaries and surrounding my womb and digestive system due to have IVF when BMI is lower than 30. So, how successful is IVF within this situation? And why a BMI is important?
Nora, you can go.
Yep, okay. So one important factor we will think about is age and, of course, the AMH. So what's your baseline egg reserve? If the tubes have been tied, that's fine. It doesn't affect the pregnancy rate. It might actually be helpful if they were damaged tubes. That's it'll help the embryo grow. So it doesn't really change anything because we bypass the tubes. What was the other part of the question?
The BMI, Dr. Nora. Why
So the
BMI?
BMI, when we think about putting an appropriate dose, so we think of two things. It's better response to the medications when the BMI is lower, and the other thing is to reduce the risk for pregnancy that can come with increased weight, like high blood pressure, diabetes in pregnancy.
Thank you so much. And can I just ask, it has to be lower than 30, or patients still can access treatment with high BMI? Because I think this is the most controversial metric. I keep seeing that patients get rejected, and I don't know how fair it is if the BMI is 30.
So this is one of the NHS criteria that they put, where the BMI needs to be between 19 to 30, so not too low and not too high either. Is because, it's believed that the highest success would occur in this range of the BMI. But again, we do offer treatments on self-funded basis to higher BMIs, and it can be successful. So we take more than one factor.
Thank you so much, Dr. Nora. So we would perhaps would like to see BMI 35 and a bit lower, but definitely with the BMI 30, we would not consider to cancel the treatment and wait longer. Okay, next question. Just bear with me. Keen to know evidence on association between deep infiltrating endometriosis in pelvic and early miscarriages 6 to 8 weeks, despite having intensive immune treatment, including hydroxychloroquine, prednisolone, metformin, Clexin, progesterone, and cyclogest. I'm struggling to understand causes of miscarriages since there are no signs of endometriosis in ovaries as per the ultrasound scan, and I have been told to just control inflammation through immune medications. Any thoughts on this and treatment approaches that are evidence-based would be appreciated.
Yes, I mean, unfortunately, endometriosis can be associated with miscarriage as well, recurrent miscarriage. And there are two main reasons for it. One is, again, what we mentioned earlier about the egg quality. There is some evidence that says that egg quality could be influenced by the endometriosis. And this can affect many things, and it can affect the chromosomes as well, perhaps. It's not something which is proven, but suspected. And that is the commonest cause of miscarriage. If there's a chromosome defect, then this can lead to abnormalities that mean that the pregnancy can happen, but usually the pregnancy will be lost in the first trimester. And it's nature's way to prevent abnormal babies from being born, and that the pregnancy doesn't go very far. So that's the commonest cause of miscarriage, but it's not the only cause of miscarriage. And even if the embryo is genetically healthy, there can still be a pregnancy loss. I mean, this woman has already taken some immune treatments. You mentioned hydroxychloroquine, steroids, progesterone. So all of this is helpful, but what's important is to tailor the immune treatment to the case. And there should be, ideally, she should have done an immune test looking at things like natural killer cells and cytokines. Sometimes we do start some treatment before pregnancy, before IVF starts, such as Humira or hydroxychloroquine. And then during the IVF, before the transfer, or during the pregnancy, we may also add in something which he hasn't mentioned, which are IV drips, which could be, for example, intralipids, which is a soya-based drip, or sometimes for the more severe cases, we use IVIG immunoglobulins. And that might need to be done kind of every month in the first trimester at least, to control the immune activity in ways that cannot be done just with the steroids or the hydroxychloroquine. You may need some additional treatment. So yeah, I think the age of this woman is important. Has she had any of these miscarriage products tested for chromosome defect? Do we know if there was any chromosome abnormality or not? And has she done immune testing or not? And then we can kind of look at what approach should be taken exactly.
Thank you so much, Dr. Sami. My heart is honestly in pain reading all of the questions, what patients have been through. I have PCOS diagnosed by scan and endometriosis only diagnosed clinically. No laparoscopy, been waiting for 7 years. I had a very low blastulation rate, 22% of fertilized eggs. So what can help endometriosis for better blast rate? And what is the best frozen transfer protocol? Very good question.
Yeah, it's a good question, actually. So, I mean, blast cyst formation rate, it can vary. It can vary with age. We know that older women have lower blast cyst formation, so less of the fertilized eggs are going to make it to day 5 or day 6, which is the blast cyst stage. but also there's individual variation. And again, when we mentioned about the egg quality earlier with endometriosis, that's one association. It can be that can affect the egg quality and therefore the number of blastocysts which form. So that could be the reason. Maybe sometimes, if you can control the inflammation, that can help. What protocol for the frozen cycle? I don't think it makes a big difference really, but I don't, this is something I always get asked, what's the best protocol for adenomyosis, for endometriosis, for PCOS? I don't think there's necessarily one protocol that works for just that. I think you have to look at the whole picture together. Everything has to be kind of assessed before you can choose the right protocol. But to be honest, I don't think it makes a big difference, because even when we give estrogen, which is something that people worry about when they do the frozen cycles, they say, oh, I'm going to have estrogen. The estrogen is much, much less than what is produced naturally when you go through IVF, much less. And we try and keep it kind of close to physiological levels. That's the whole aim. So even if you're taking estrogen artificially, we don't really want to push up the estrogen to huge numbers that you get with the IVF, where it's in the several thousands. It's not going to be like that. It should be kind of 500, 400, 600, something like this. So I wouldn't really worry too much about the protocol itself. Maybe when you talk about protocol, if this is someone who's had repeat implantation failure, repeat miscarriage, what additional drugs should be added in? Does she need to have immune testing? Do we give blood thinners, things like this? Yes, that's important. But the actual technique for doing the frozen transfer, I don't think that's too important, really.
I think that is something I can add here by perhaps just defining what exactly is good protocol is very closely monitored. And this is exactly what makes the difference. When we perform the blood test, we precisely know if we have to increase the dose, even of the estrogen, isn't it? When it comes to progesterone, we monitor it so precisely. And this is what perhaps may make difference.
You reminded me, Maria, also one thing which is important, because we mentioned earlier also that the endometriosis can affect progesterone receptors. And there is some evidence that says that you should give higher dose of progesterone with endometriosis patients. And definitely, at Plan Your Baby, we're very focused on giving a healthy, good amount of progesterone. We're not skimping on progesterone, because that is really important, and especially more so for endometriosis patients.
Thank you so much. Another question, I have never been given a diagnosis of endometriosis, but I have been trying to conceive for more than 10 years and haven't been lucky. So the fallopian tubes are patterned, and lady has regular cycles, and now she's 42 and still trying to be a mom for the second time. What can be advised? And the AMH is 0.7, Dr. Sami, Dr. Nora.
Nora, do you want to do this?
Yeah, so I know that, the tubes are patent, but again, age affects egg quality. At 0.7, it's considered a low egg reserve, but it's not something you've done wrong. It's just that we're born with 2 million eggs, and as we get older, the eggs reduce in number and in quality. Some people still would like to try to have a cycle of IVF, but at this point, even IUI, meaning, insemination or, having a natural cycle versus IVF can give the same result, because, it's just trying to work with what we have, basically. So the odds aren't really high in success, but at least you could still try. But you could also still try naturally as well, because we can't change the egg quality, but we can always try to bridge any gaps between the sperm and the egg.
Thank you so much, Dr. Nora. Another question. Hello, my name is Mercy from Nottingham, UK. Please, can I have a question? I had a surgery to shave off my endometriosis, drain cyst, separate adhesion, and unfortunately my left fallopian tube was removed due to the damage endometriosis has caused. I was told that my right fallopian tube was blocked. So my wonderful doctor is suggesting IVF. I was initially prescribed Lingalix, before I had the surgery. Now the doctors have asked me to stop the Lingalix if I want to try for pregnancy, but there are chances of ectopic pregnancy, endometriosis regrowth. I honestly don't know if I should just continue the Lingalix till I do IVF, but the problem is because my doctor has asked to stop it, he might not prescribe it again. Please, any suggestions?
Okay, so the Slingalix is it's Ucelty. Some of you may know it as that, and it's a drug which is orally given to suppress endometriosis, suppress the estrogen. It's a GnRH antagonist, which we mentioned, which is quite a new drug actually. So it's a nice drug.
Yeah, it's a combo.
So, yeah, it's something we didn't have before. And yes, it should help to minimize the endometriosis. The problem is because it blocks the estrogen production. If you take it for a long time, that's actually not good. It can affect bone density, and you're pretty much into a menopausal state. So it's not something that you can just keep going forever with, because otherwise there's going to be side effects and problems. And certainly if you want to do IVF, then we probably would want you to stop it for a couple of months to allow the ovaries to wake up, because the ovaries can get very sleepy when they've been suppressed for a long time. And then when you do the IVF, you just don't get a good response. You don't get many eggs and embryos, and that will limit your chance. So it has to be stopped if you're wanting to do IVF. And it needs also, if you want to do some assessments as well, some fertility tests, hormones, again, you need to be offered to be able to assess these things. So it needs to be stopped probably for a couple of months before you start any IVF, to allow these tests to be done and for the IVF to happen. Yes, unfortunately, there can be regrowth. That's true. But, it should be kind of planned that you have your IVF booked in and ready, that you don't stop the drug and then you have to wait extra months for the IVF to actually start. So it has to be kind of coordinated with your clinic. This is when you stop it and this is when you're going to do the IVF. And yes, ectopic is more, there's more risk. I mean, she's already had one tube removed, so that's going to reduce the risk because that tube is gone, but there's still possibility on the other side. It's less likely to happen with IVF in situations where the tube is damaged, because we go the other way. We go through the cervix into the womb. We don't usually go in the tube, but you can still get, even with IVF, ectopic pregnancy, but it's less than 3% chance. So it's not a high risk. I don't want her to be too scared of IVF because of ectopic. Yes, we can't prevent it 100% or predict it, but it's not a huge thing that we see very often, thankfully.
Thank you so much, Dr. Sami. The next question is very interesting, and I think many patients will resonate with this. So first of all, thank you for inviting us to this session. Very grateful, and the Q&A session. I'm keen to learn how to cope with periods to prepare for then start trying for pregnancy. I'm not yet in a position to resume my periods due to the incredible pain and bleeding. So that is my biggest blocker.
So we did talk about surgical management for endometriosis, and we use medical management such as injections to stop periods completely, or continuous combined contraceptives. And these are, they're not going to help you get pregnant at the moment, but stopping them is completely reversible. So they're just a bridge until you feel ready to get there. But again, just put a contingency plan or a plan when you want to seek to get a family, because again, depending on what your baseline AMH is or your egg reserve, you don't want to come 10 years later and realize that with age, the egg quality is being reduced and the egg numbers also being reduced. So just be mindful of what your plan is and set a plan. But they don't really harm anything. So
yes, thank you so much, Dr. Nora. Next question. I had laparoscopy surgery in 2017 due to endometriosis and had CT scan in 2025. Was told that it's back and there are multiple small ones. I guess it's cyst or growth. I always get very painful periods and very nasty lower back pain. It affects my daily activity. I stay in bed for 2 days and bleeding is heavy for 3 days. It's causing me anxiety, depression every month. Please, can you advise, because I'm failing to conceive?
Yeah, this is a very sad situation, because sometimes the endometriosis can cause so much pain. It's really destroying this patient's quality of life. And because she's already had surgery, to go back in and cut away again, the endometriosis is going to be causing, maybe, like we mentioned, a drop in her egg reserve and making it more difficult then for her for getting pregnant. So it's a bit of a difficult situation to find yourself in. You can't take things like contraceptive pill, like Dr. Nora mentioned, because that's going to stop you from trying naturally. So I'm not sure how long she's been trying to conceive for. She didn't mention that, but I think if you haven't been able to conceive for a while, make sure that you've had assessments for both you and your partner, because maybe something is being missed that's important. that needs to be addressed for you to be able to get pregnant. You know, are you having good hormones? Are you ovulating? Is the sperm okay? Do we need to think about checking your tubes perhaps? You know, what was your endometriosis surgery showing before? All of these things should be looked into. And then if necessary, you know, think about IVF, especially if it's been a long delay in you getting pregnant and you're suffering. Like Dr. Nora mentioned, hopefully when you're pregnant, the endometriosis will settle down for a bit. It never goes away completely until you go through menopause, but at least you'll have a little bit of a break for 9 months or so. But yeah, I think maybe thinking about IVF, or if you're not ready to do that, maybe embryo freezing, and then perhaps think about surgery afterwards, or egg freezing if you're single. You know, these are things that you should be thinking about if it has been a reasonable amount of time trying. If it's only been a couple of cycles, maybe you can try a little bit longer. But of course, you know, it's quite a big impact that can have on someone's quality of life. So it is worth getting investigated properly, and not leaving it to last minute.
Thank you so much, Dr. Sami. We have another question. I have stage 2 endometriosis, which has been successfully removed via ablation. This was my second surgery in a year. I also have adenomyosis with the 8-week bulky womb and also a tilted womb. I'm now naturally trying to conceive and 6 months with no luck. I have just had my progesterone bloods done today, but what else can I do to get better chances of conceiving? As my consultant said, it would be best to get pregnant this year before endometriosis gets worse and my adenomyosis develops.
So her age is another factor. The other thing is, have they had the sperm checked? You know, have they had tubes checked, especially if that she's had surgery? So if the tubes are blocked, then there is no, you know, trying naturally is not going to be helpful. They need to go for another way. If the sperm is affected, then we need to see if IVF could bridge the gap, or ICSI. So these variables need to be assessed and checked before actually telling such a patient carry on for another 6 months or 1 year. The point that they were trying to make is, as soon as after surgery, to get treatment or pregnancies to try and suppress the condition as much as possible.
Thank you so much. We have many more questions, so I will ask a few more, and then please, if my colleagues can help me to provide the email address, so we can support then everyone over the email, or please simply book the call with the doctor to discuss your questions. Hi, joining from Shropshire, or I couldn't even pronounce correctly. I'm sorry. I have had a recent within the 6 months surgery for stage 4 endometriosis involving bowel and adenomyoma removal. Endometriomas under 2 centimeters remain, so no surgery on the endometriomas. 9.7 is the AMH. And lady is 32. I still have adenomyosis diffuse. IVF frozen transfer failed. Would you recommend suppression for future?
So yes, I mean, this is very unfortunate. This lady who's got quite severe endo, very severe endo, bowel involvement, and she also has adenomyosis, which sometimes they come together as well. Very good that they didn't operate on her ovaries and didn't remove the endometriomas. Definitely 2 centimeter endometrioma should be left alone. Please, you know, don't touch those, because that's going to further drop her egg reserve, which is already a little bit on the low side. 9.7 at 32 is on the lower side, but it's not too bad. She's already done IVF. She's got frozen embryos, I think, and she transferred already at least one, I'm not sure, but embryo, and it failed. So this is not an unusual thing that I see this unfortunately a lot of the time, because even with young women, you know, with endometriosis, with even if the embryo is really good, there can be reduced chance for getting pregnant. And when I first started doing IVF 15 years ago or so, we used to do this long suppression. So we used to give the long GnRH agonist for 3 months. We used to give it before the cycle. This has fallen out of favor now. The recent studies now show that this doesn't benefit. The only thing it does is give menopausal symptoms, and, you know, headaches and flushes and night sweats and all horrible symptoms, without actually impacting the success rates and the pregnancy rates. So the European guidelines, the American guidelines now don't recommend this. Maybe for severe adenomyosis, which we're not sure if this lady has severe, there may be still some room for it to be done, but it's not for most cases anyway. But what may be more important, more relevant for this lady is checking her immune system, because sometimes, like we mentioned, there can be chronic activation of the immune system in ways that make the body very unfavorable for pregnancy. And it can be hard then to get pregnant, or it can be miscarrying. And therefore, I would suggest, if she hasn't already done that, to get some immune testing done, checking natural killer cells, cytokines, some autoantibodies. And then from these results, a plan for the treatment can be done, which will hopefully calm the immune system and allow our body to be more accepting of the embryo and give a better chance. So that's one thing that can be done, rather than just giving 3 months of down regulation, which I don't feel and the research doesn't show is important.
Thank you so much. I know we're out of time, but I have one more question, if you don't mind. Please answer. I think it's very, very interesting. So what is done about high level of pelvic inflammation with endo causing CA 125 level between 46, 52 throughout the cycle, with no sinister cause found after thorough checks confirming no sinister cause? I think this is very, very interesting question. If you could please address it.
Nora, would you?
Yeah, so CA125 is known as a tumor marker, and it's usually a tumor marker for specific types of ovarian cancer, which can be very scary. However, there are other reasons why this, protein is high in the blood, and endometriosis is one of them, and it's a benign cause of why this is increased. Yes, I know that you may read a lot on the internet, but also in research, it may be very rarely the endometriosis is associated with a subtype called clear cell tumor in the ovaries. And that's why, having your continuous surveillance and being checked and followed by your endo team can make sure these are good. But that type does not have any effect on CA125. You can have a really large endometrioma with a high CA125 and it's completely benign. As long as you've ruled out everything, we don't need to monitor it during the cycle. There's no value in repeating it because we already know, and especially if it's a young patient and it's a typical cyst in the look, an MRI can also give us that reassurance, and we don't really need to worry about it.
Thank you so much, Dr. for such a reassurance, because I think, when it comes to fertility treatment and those conditions and, any risks to have cancer, it's always very, very, very scary. So thank you so much for your reassurance. So unfortunately, we have run out of time. I can see we still have questions in the chat, but I promise you we will address them, and we will have the recording of this webinar. And this topic is just huge, and it's affecting so many of us, and it's so important to get the answers. So if you feel that you have not heard the answer to your question, please feel free to book a free call with Dr. Nora or email to us, and I promise our team will get back to you. And again, thank you so much for joining, and I hope you really enjoyed the session. And Dr. Sami, Dr. Nora, you are, as always, brilliant, fantastic. And honestly, every time we do webinars, I learn so much myself. So honestly, thank you so much for doing this for all of our patients.
It's a pleasure. It's a pleasure. And yeah, I really hope that all of you out there have success and achieve what you're hoping for.
Me too.
Thank you. Thank you so much, everyone. And I hope you will have a nice Tuesday evening. Good night, everyone.
Good night.